Hi everybody, so this is the video for Study Guide 1. We're going to go through 4 cases together. It's interactive. I'll show you what I mean in a moment, but I strongly recommend that going into this you have a pen and a piece of paper handy or whatever you want to write with, because this is a chance for you to write down some answers. First of all, I apologize if this is hard to hear. We're in the middle of a heat wave and I have a fan blowing in my face, and I really am hoping this is not going to be a big distraction and you'll be able to hear me okay. Okay, first case. We have a 79-year-old man who is hypertensive. He's got atrial fibrillation and he's got coronary artery disease. He's on a couple of antihypertensives. He's on a statin and he's on warfarin. And I circled warfarin here because that is something you want to know in neurosurgery, right? This month, when you hear that somebody's anticoagulated or somebody's on aspirin or Plavix, you want to note that and you want to highlight that because our patients are having trauma, having surgeries, at risk for bleeding, at risk for clotting, so it's an important detail. This patient lives at home with his wife and he's independent. One day he's on a ladder cleaning out his gutters when he slips and falls down, hits his head. His wife helps him up, and for the next hour or so he's coherent and talking. They don't take him in anywhere because it doesn't look like anything's broken, but he does have a bruise on the left side of his head, so he clearly did hit his head. Over the course of the afternoon he begins to get worse. So that afternoon he complains of a headache and goes to lie down on the couch. When his wife goes to check on him, he's drowsy and he's slow. So he's slow to respond when she asks him questions. She kind of has to keep shaking him to keep him awake. And he can't open his eye, his left eye, all the way. It looks like this. And to open it all the way, he actually has to do this. So his wife now realizes something's not right. So she goes to call 911. And when she comes back to him, he can't move his right side. And what I mean by that is that his right arm is flaccid, can't move it at all. His left leg is weak, and the right side of his face maybe is even a little bit weak, the lower part of his face. By the time medics arrive, she can't even wake him up at all. Nobody can wake him up. He's comatose. So, So pausing the video, when you see this icon, that's a reminder to you to get out your pen, your piece of paper, whatever, and I want you to answer these 2 questions. So what happened? And maybe you can come up with more than possibility. That's great. And then what hemisphere is affected? And your hint is that he's got a left-sided ptosis and a right body weakness. So pause the video, answer those 2 questions, and then come back. Okay, hopefully you paused and did that. This was my differential diagnosis. It's not exhaustive. I'm sure we could think of a million other things as well, but these were the things that rose to the top. So I think pretty clear that we're all worried about some kind of traumatic intracranial hemorrhage. He hit his head. He's anticoagulated. So is it a subdural hematoma? Usually we think of subdural hematomas as being kind of slow growing, slow progressive hemorrhages because they're under venous pressure. But he's anticoagulated, so even a subdural hematoma can be very aggressive in somebody who's anticoagulated. But it could be an epidural hematoma too. Those are often under arterial pressure, and so they can expand very rapidly. And there is certainly this talk and die phenomenon that's described for epidural hematomas that sounds very similar to our case. So my guess is it was a subdural hematoma with uncal herniation, but it could have been an epidural hematoma. I think it's left-sided, and we'll go through localization next, why I am convinced this is left-sided. And, I think there is, also a possibility of another etiology as well, and that is that he had an ischemic stroke. So it may be that while he was on the ladder, he had a TIA, got better, and then later, perhaps when he was lying on the couch, suffered a completed stroke that localized his brainstem. Okay, so here's his scan, or this is a picture of his CT, and so I want you to write down what is the diagnosis. Based on this, what is your diagnosis? And then also, can you identify these structures? So pause the video, write your answers, and then come back. Okay, so let's go back to this. so what is the diagnosis? He's got a left-sided acute subdural hematoma. I'm not going to go over all the imaging details. I certainly could, but we don't have enough time. There's clearly mass effect, and there's clearly midline shift, right? If you are struggling with what that means, mass effect, midline shift, I refer you to the neuroimaging video early on, or perhaps one of the book chapters on neuroimaging to brush up on that. So what are these structures? So on CT, it all revolves around density. So black is least dense. What's the least dense thing you can get in the head? Air. And so this is air in the sinus, specifically in the frontal sinus. So other places you may see air in the head if a patient has had surgery. They may have pneumocephalus. And then back here we have the opposite. We have hyperdense structures. So as hyperdense as it can get, really, really white like this. Usually on the CT scan, the whitest things are going to be the bone. And this is, you can see the skull here. And then you can see some also, you can also see some other calcified structures. And that is the choroid plexus here and here, and then the pineal gland here. So, okay, so this is his scan. It's just a few cuts down below. And what we would like to see around this level is this, right? Everything's a face. We can't really see this. But what we would like to see is this. And we would like to see his midbrain. And we would like to see the cerebral peduncle over here. What happened is that our patient suffered uncal herniation. So the lip of the temporal lobe, depicted here, and then depicted here on this coronal view, got pushed over because there's a mass lesion, an expanding mass lesion in the middle cranial fossa. And when it compressed these structures, it led to his clinical presentation. So how does that work? Well, so the cerebral peduncle here in the midbrain contains the descending corticospinal and corticobulbar fibers, so our motor fibers. And so those have been disrupted due to injury to the cerebral peduncle. The third nerve, we don't see it on this illustration down here, but you can see it up here on the coronal view. The third nerve is, of course, the oculomotor nerve, and it does a number of things. Damage to it can cause ptosis, as we see in our patient, and we'll go over that a little bit more. And then the PCA, the posterior cerebral artery, also hangs out in this area, so sometimes that can get damaged. Sometimes there can be enough compression of this artery that it causes a stroke. So, uncal herniation. This is a good pattern for you to know. So 3 things that you should think about when you think about uncal herniation. So coma, like our patient. The reason coma happens is because of the reticular formation. So you remember there's this series of neurons that travel down through the brainstem. And those, when those are damaged, that can cause coma. So the combination of coma, ipsilateral third nerve palsy, and contralateral hemiparesis should make you think uncal herniation. So let's back up a bit here. So the third cranial nerve 3 does 3 things. It keeps our eye open due to innervation of the levator palpebrae superioris. It keeps our eye open. When it gets knocked out, you get a ptosis. It moves our eye. So we have, 6 muscles that move our eyes, and all but 2 of them are innervated by the oculomotor nerve. The 2 that aren't innervated by the oculomotor nerve are the abducens and the superior oblique. And when you only have those 2 muscles working, then you get a down and out deviated eye. So we don't know from our story so far if our patient has a down and out deviated eye, but I bet he does. And then the other thing that the third nerve does is it mediates the pupil, and it mediates especially the parasympathetic input to the pupil, which causes the pupil to constrict. When you have damage to the third nerve, damage to the parasympathetic input to the eye, you get a blown pupil. So the pupil is enlarged and it's non-reactive. And that's very likely what our patient has. So then the contralateral right hemiparesis is exactly as we just explained. He had damage to his right-sided or his left-sided cerebral peduncle. Sometimes you also hear the term crus cerebri, and that caused a contralateral, in his case, a right-sided hemiparesis. Oops. Okay, so just a few finer points. Sometimes when a patient gets an oculomotor nerve palsy, you don't see all three things. You might just see two of them or one of them. Oculomotor nerve palsy can happen for a lot of reasons. You know, in neurosurgery, we think about compression, but it could also be stroke. It could also be, you know, not just compression from uncal herniation. It could also be compression from an aneurysm, specifically maybe an aneurysm of the PCOM, the posterior communicating artery. So that's one reason for oculomotor palsy is compression, or stroke, I guess. You can also have microvascular disease. And if anybody's going into primary care or emergency medicine, it's worth spending a little time learning about pupil-sparing third nerve palsy. I'm not going to go into it here in the interest of time. And I told you that with uncal herniation, the typical pattern is a contralateral hemiparesis. Very rarely you can get an ipsilateral hemiparesis. I'm not going to talk about this, but if you have an interest in learning more, just Google Kernighan's notch. Okay, so as I mentioned, you know, patients can, if they have herniation bad enough, they can damage the posterior cerebral artery or compress the posterior cerebral artery. So just a reminder of the blood supply. So the posterior circulation back here, so the vertebrals join together to form the basilar, and then out here the posterior cerebral arteries. Up here the anterior circulation, so the carotids, and that goes up. They go up to form the middle cerebral and the anterior cerebral arteries. And then you remember the circle of Willis that joins the two, so it allows communication between the anterior and the posterior circulation, and also the right and the left circulation. So not all of us have a complete circle of Willis. The PCA over here. So our patient could have, we don't know, but he could have damaged his left PCA, could have compressed it in his uncal herniation. If that was the case, what would we expect to see on exam? So pause and write that down. Okay, that worked for you. So we don't know, right? Realistically, we don't know if our patient has this because we can't examine him. He's in no state to really find out. But, you know, once the dust settles, once his life is hopefully saved, we can look to see, did he suffer a stroke of his PCA territory, and is he symptomatic from it? So over here is a depiction of the posterior cerebral artery territories on the left and the right hemisphere in the blue here. And it's the occipital lobe, the medial temporal lobe, and thalamus that are the main structures that you think of when you think of PCA. So given that, what kind of deficits would you expect? So from the occipital injury, I would expect a contralateral homonymous hemianopsia. Maybe you probably would have macular sparing, which isn't depicted here. But that would be very likely. And then possibly also some contralateral hemisensory deficits, so depending on where in the thalamus you had injury. Okay, so headache and vision loss. There's a lot of red flags here. Later we have a video talking about headache, and there's a section talking about red flags. So things that should alarm you when you're hearing about people's headaches. And this patient is rife, his story is rife with red flags. So he's a 68-year-old man. He starts having dull, low-grade headaches relatively late in life. And then they continue and get worse. So that's all a red flag. The headaches also are worse in the morning and when he awakens. That's worrisome because that could be an indicator of high intracranial pressure. He has no prior headache history. He's otherwise healthy, takes no medicines. He recently quit smoking, and I circled that because that's one of those little facts that we just don't want to lose sight of, kind of like the warfarin. So he undergoes a neurologic exam. He gets, as part of that, he gets confrontational visual field testing, and they pick up a problem. So he's got a right upper quadranopia, right? So our last patient had a hemianopia. This patient has a quadranopia, same hemisphere, or same, I should say, same side. So where does this localize? We know that we're dealing with a problem in the brain because he's got headaches and he's got vision changes. But where? So we're probably thinking left hemisphere, right? Because just like our case before, who had a left brain lesion and a right visual field cut, that's probably going to be the case. But specifically, where in the brain is his lesion? So pause, give a guess, and come back. Okay, so this chart, I would spend some time, if I were you, I would spend a little time with this chart. We're going to certainly go over things a lot over the course of the month regarding this pathway because it's so important for neurosurgery and so important for neuroscience. So it's very useful for localization. So spend some time on this. Remind you, so as you're reviewing how the visual apparatus works, so after the visual fibers leave thalamus, they have to get back to the occipital lobe. Some of them go through the temporal lobe, some of them go through the parietal lobe. Those that go through the temporal lobe concern the upper field. Those that go through the parietal lobe concern the inferior field. And so if you have a lesion affecting the upper fibers of the right hemifield, you can bet that that localizes to left temporal area, left temporal lobe. So given all of this, come up with a differential diagnosis. Try to think of at least 3 things if you can, and then come back. Okay, these were the things I thought of. So brain tumor, right? Got to think of a brain tumor. The positional headaches are really worrisome to me. So what kind of brain tumor? I would think most common would be metastasis, and we'll talk more about that. But he has a smoking history. And then, it's also plausible that he has a high-grade glioma or he has a aggressive meningioma, some other kind of brain tumor. Maybe an infectious cause. This is kind of a dumb slide because I realize now that brain abscess and HSV meningoencephalitis, those are pretty aggressive conditions. And his symptoms have been going on for a couple of months, so those are probably a little less likely. But maybe some other CNS infection, maybe some kind of slowly percolating, indolent kind of CNS infection. And then the other thing I thought of was AVM. So maybe he had a left temporal AVM that created some mass effect, contributed to his headaches, and then affected his vision. So a number of things. And again, I'm sure you guys thought of things I didn't think of. We know enough to know from this that we have to image him. So which cancers, pause and tell me, which cancers are most likely to metastasize to the brain? Okay, before we go over that, I just wanted to point out this is kind of a cool website, kind of some cool materials too as you review this stuff. These materials are designed for patients, but they're kind of sophisticated and really well done. Okay, common brain mets. Lung, of course, #1, breast, melanoma, renal cell, and some people would also say colorectal cancer, but these are more common. So some things to know about mets. One is they can be solitary or they can be multiple. Another is that they like to happen in the supratentorial space, so the upper top part of the brain, as opposed to the cerebellum and brainstem, though certainly you can occasionally see something like cerebellar mets. They like to happen at the gray-white junction, as you can see here, where the gray matter meets the white matter. That's a common location for them to occur. And they can sometimes hemorrhage. So as you can see here, this hemorrhaged. And in particular, melanoma and renal cell are kinds that like to hemorrhage, but really all of them can hemorrhage. So this is not our patient. These are just different pictures of brain mets. Imaging. So anytime that you're worried about malignancy, infection, or inflammation, you're going to want to have contrast imaging. So just keep that in mind. Okay, another headache. This is a very similar story, right? So this is a woman in her 60s, goes to see her primary doctor, healthy, no problems, except headaches that are waking her up at night. So very much like our last patient. Sounds like she's maybe been having some other symptoms, maybe some cognitive symptoms. And on your exam, you notice, yeah, she does have some cognitive issues. And she also has some subtle left leg weakness and an upgoing toe on the left. So we'll skip your differential diagnosis. We went right to getting a scan. This is a contrast scan. This is an MRI, and this is post-gadolinium MRI. And I want you to tell me what the diagnosis is. So come back after you've done that. Okay, so it was a parasagittal meningioma. So I think we had maybe this exact image. It now occurs to me on Study Guide 1, but this is just classic for meningioma. It's along the falx. It's so uniform and round, uniformly enhancing. We don't see a dural tail here, but sometimes you can see a dural tail on some of the sequences. What you should notice about this is that it really, is hard on those midline structures, right? The middle part of the brain, because the falx goes down between the hemispheres. The other thing you should notice is that there's not a lot of edema, right? We just talked about edema with METs. You don't really see it you do see it with some meningiomas, but you don't see it in this particular meningioma. So this is a parasagittal meningioma. It's probably been there decades, right? And slowly growing. You'd think the patient would be incredibly symptomatic, but because it's been so slow growing, the patient and the patient's brain adapt over time. So this is a good thing to know about. Why does it affect the leg? Well, because remember, this middle area here, where the motor fibers for the leg are located, has been compressed, especially on that right side, so giving the patient a contralateral leg weakness. And no surprise that this patient would be having some cognitive problems, right? Because the frontal lobes, we know, are so important for cognition. Okay, last case. I think it's the last case. We've got a young girl. She is brought to clinic by her parents. And I should tell you guys, this is a tough one, okay? So I wouldn't expect you to know what is going on with her or to be able to figure it out from here. I just want to highlight, this is kind of more a show and tell, to highlight some things. But this little kiddo, she's been having trouble walking. You know, she was doing fine, and then she just kind of regressed. She's clumsy, she's slow, she can't keep up with her friends. Her neck hurts, and her arm and her shoulders are numb. Sometimes even her hands are numb, maybe even a little weak. It's hard to tell. She gets terrible headaches, especially when she coughs. So she goes on to get imaged, and this is what we see. Here's her spinal cord and her brain. This jumps out at you, right? This big cystic lesion here. So yeah, in her spinal cord at what, like C2, C3, C4, at C3, C4, C4, C5-ish. She, more C3, C4. She has this cystic lesion in the center of her spinal cord, and you can see where it makes her spinal cord space occupying. It expands her spinal cord. So you can imagine that it's compressing some of those midline structures in her spinal cord. And then she's also got an abnormal brain, so you can see the cyst down here, but you can also see this abnormality here. So her cerebellum, the tonsil of her cerebellum extends way too low below the foramen magnum, and this all is compressed in here. So she has a Chiari-1 malformation. That's the brain malformation here. And then she has an associated she has an associated syringomyelia, or syrinx, as her secondary thing that's going on here. Syringomyelia. So syrinx, let's talk about that. This is a fluid-filled cavity in the spinal cord, and it can come from trauma, tumor, but it can also happen from developmental anomalies like hers, Chiari-1 malformation. And it causes weakness, numbness in the arms and hands, this kind of cape distribution, sensory loss. And the reason for that is because if you look at least the corticospinal and the spinal thalamic tracts, the way the fibers are organized in the spinal cord, those fibers are most likely to be impacted first and more severely by a process happening in the middle of the spinal cord. Make sure to read up a little bit on syrinx, and then make sure also to read up a little bit on Chiari-1 malformations. And that is the end of this video. I, again, hope you weren't too distracted by the fan, and hope it was helpful, and I will see you guys later.